Thank you, Dr. Shish. Been a wonderful session so far. I hope you could see my slides and I am audible as well.
Yes,
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 ma'am.
yes, doctor.
Yeah,
Yes, Dr. Vanatha.
thank you. So, as we all know, dry eye diagnostics is a real vast topic to speak upon. I would just speak on what's perhaps relevant and will be applicable to clinical practice or in a day-to-day adoption while you're in your clinic. Have no financial interest in the mention of any of the devices during the course of this talk. We have now understood that the tear film model has evolved from what we traditionally knew as a lipid, aqueous, and mucin layer to a superficial lipid layer, which contains both polar and non-polar lipids, and a mucin aqueous combination, which is a layer of aqueous containing soluble mucins and proteins along with water and ions, and a glycocalyx layer which is closely incorporated or integrated with the microvilli of the epithelial cells in the mucin region. So with this understanding, we now go on to see how the normal ocular surface, which is a combination of a lot of the ocular surface in nexa and the cornea conjunctiva, we will need to understand that whenever there is drying of the ocular surface, then whenever there is drying or whenever there's damage to the tear film here, this leads to the damage of the aqueous, lipid, and the mucin layer, thereby damaging the glycocalyx and the microvilli here. And with persistent damage onto the ocular surface because of the tear film disease, the ocular surface disease, this leads to further desiccation, damage to the microvilli and the epithelial cells, which then tend to fall off the normal ocular surface, as you could see, as this animation is nicely depicting. And these leave damaged epithelial cells, which you could look at by your epithelial staining. And with the severity of the grade of damage, you would have more problems and which need to be tackled as you are managing dry eye cases in your clinic here. So we'll just move on to the diagnostics part of dry eye disease here. And the DUCE2 recommendations here give you a triage of about 8 questions or so, which you would like to direct to your patients. And these questions help you to identify the causative risk factors which will be responsible or which are probably responsible for the etiology of the dry eye disease in your particular patient. There are a whole lot of questionnaires which can be adopted for dry eye disease, for contact lens wearing or induced dry eye disorders and other disorders. But something which is more important or which is more relevant or recommended by the DUCE2 is the Ocular Surface Disease Index questionnaire and the dry eye questionnaire, the DUQ5. There are plenty others, and you could always go and look up these. But according to this DUCE2 recommendation on the diagnostics methodology, following the application of a triaging questions to a particular patient, which helps to identify the risk factors which are positive or the etiology which are responsible for the dry eye disease, which also give you pointers to the type of dry eye disease your patient has. You then would move on to adopting the diagnostic tests, which can per se be screening tests or which look at the homeostasis, the tear homeostasis here. For the screening fact, you could use these one of the two the questionnaires, the OSDI or the DUQ questionnaires. They are simple self-administered questionnaires which the patients can do themselves. And when the score is over 6 in a DUQ5 or over 13 on your OSDI, combined with one of the homeostasis markers, which is a decreased TBUT of less than 10 seconds, the tear osmolarity fallen over, tear osmolarity is again affected, or the tear osmolarity difference between two eyes is over 8 milliosmoles. And again, an ocular surface index with the significance on corneal conjunctival staining. And the tear lid margin staining is more than 22 millimeters or more than 25%. These will be definite diagnostics to categorize your patient as a dry eye disease patient, the severity of which can be graded into mild, moderate, and severe, depending upon on further elaboration into identification of whether it's an evaporative, aqueous dry eye disease we're dealing or a combination of both. So that sort of summarizes how you would adopt, or what's the approach or the protocol you will adopt in management of dry eye disease in your clinical practice. Again, this is an elaborative look at the at the OSDI and the DUQ questionnaires, which is almost freely available on the net. A simple diagnostic test is looking at the tear film stability is your TBUT, which you could just do. It's an invasive. You can stain it with fluorescein and look at. You will find dark spots on the tear film surface here. What we now have is advanced diagnostics in a dry eye suite in your clinics is the luxury of using an ocular surface analyzer, which can sort of quantify all these multiple ocular surface evaluations within a short period of time. It can give you a look at the meibomian gland morphology. It can give you a tear meniscus height, the non-invasive TBUT, and also quantify the lipid component of the tear film, and gives you as a diagrammatic representation along with the values. The diagram is a quadrant of the clock dial image, which points to the safe area, suspicious area, or the severe area which the patient falls into here. So we'll quickly run through a few of these examples, or how this really helps us in our practice. That is the placido disc reflection image from the ocular surface. And once you capture this image, this helps you to incorporate and has a battery of these diagnostic tests which are available at the touch of your of a touch of the button, and you will be able to look at the results in one go, and can be easily performed by your technician, or you can perform it yourself. Again, this is the tear interferometry, which is given by the ocular surface analyzer. The white image here is the interference pattern on the lipids here, and you would look at the color birefringence, which will be imaged by this device on the surface here. The birefringence will depend upon the health of the lipid layer, and this, as the clock dial image, gives you the health of the lipid layer thickness of your particular patient. You can also quantify the partial blinks, the complete blinks, the blink rate of your patient. This is a picture depicting the lipid layer thickness, and how it changes with the effective lipid layer thickness according to the health of the tear film in a patient. So when the lipid layer thickness is less than 30 nanomicron, 30 nms, you find that the birefringence pattern due to refraction through the lipid layer is lost, and you just get this sort of a opaque pattern on the white ring here. And as your tear film or the lipid film is healthier, that produces a colored birefringence imaging on the central disc, and you will be able to see this particular pattern, which gives you an idea how healthy your tear film lipid layer is. So a closer look at a healthy tear lipid layer here when it's about 30 nm here, and here you have another where your lipid layer is not so healthy. You're able to see the birefringence pattern of colors is not as good as in this image onto the left here. So that's an imaging of the tear lipid layers, and again the values are depicted on your screens, and they also help you to compare the improvement once you put your patient or into the various treatment regimens depending on the ocular surface disease which affects them. Another test which another ocular surface parameter you can measure is the tear meniscus height. Of course, we have this simple slit lamp image which can help you to measure here, but to quantify it and to serially look at the health of the aqueous layer, the tear meniscus height imaging is a very useful imaging modality, and helps you to really quantify how it is improving when you are managing patients, or they are through a treatment protocol along with you. The non-invasive tear breakup time here, the placido disc image is closely observed by the inbuilt software, and tells you the breakup of these placido disc images, and calculates over a serial of imaging, and gives you the average TBUT time and the TBUT of the particular blink you are looking at. A closer look at the images and how the Myers get distorted here, and this is calculated on and gives you a very immediate numerical value, which helps you to quantify the particular test for the patient. Of course, you can do your NUVT or the simple plasma disc imaging or keratoscopic imaging itself will also give you the same results here. The breakup and the regions of breakup can also be elaborated in this particular ocular surface imaging. Another useful modality is the meibomian gland imaging, which you can see, and it helps to delineate the regions of affected meibomian glands and gives you the surface area and tells you what percentage of the image is of the meibomian glands are lost as well. The blink quality, as I already told you, it can tell you what the number of complete blinks, the partial blinks, and this helps you to analyze how a complete blink is absent in a particular patient. As we know, a complete blink is really essential for the equivalent spreading of the tears, and the negative suction pressure helps the expression of lipids from the meibomian glands for the good health of the ocular surface. So that's in a nutshell what you could all look at in ocular surface analyzer. The Lipiview is also yet another device which can help you to look at the lipid layer thickness, the blink dynamics, the meibomian gland structure, give you a qualitative assessment here. In particular, it gives you the tear interference pattern here from which you can draw the particular values of the parameters which you're looking at. The tear osmolarity method using the Tearlab, which is based on the temperature corrected impedance measurement, helps you to understand or helps you give a numerical value of the osmolarity status of your tears here. A little expensive, the expensive test, but and again, the value of using osmolarity in your dry eye practice is still not recommended, except for a particular group of patients where you would probably want to apply them. Simple in-office tests like ocular surface staining still play a very important role in the diagnostics and in the serial follow-up of your dry eye disease patients. And this is another slit lamp image of how you could just measure your tear meniscus height in your patient here. And other more sophisticated methodologies is using the anterior segment OCT imaging, which would help you to delineate the tear meniscus height and the tear meniscus depth. These are methods which can give you a quantitative analysis of the tear meniscus height, especially when you're using them for research purposes or for treatment follow-up purposes. They play a very good role in in imaging the tear meniscus height of your patient here. Another new non-invasive tool which is also available, it's a little expensive, can be easily procured, is the strip meniscometry. Has a central ridge here and into which the tears get sucked in when you place them at the lower tear meniscus. And this strip meniscometry also gives you a wonderful correlation. It's a non-invasive method of measuring the health of the tear meniscus height, and this corroborates well with your anterior segment OCTs with the tear meniscus depth and tear meniscus height measurements with your ASOCT. And it's an excellent non-invasive diagnostic test which can also be applied for dry eye disease here. When you move into laboratory tests, most of us do not follow do not follow our patients into the laboratory or do not advise laboratory tests as tear lysosomes, tear protein, and tear lactoferrin unless you are onto a research for these patients here. And confocal microscopy, I think we'll have more on this coming to you shortly. And the imaging here is to look at the health of the superficial subepithelial nerve plexus and the epithelial cells, which will tell you about the dry eye disease affection of the cornea. With that, I will close, and I thank you for the opportunity to be part of this excellent instruction course. Thank you.